বাংলাদেশ ইনস্টিটিউট অফ ইনোভেটিভ হেলথ রিসার্চ BIIHR এই আজকের জার্নাল প্রেজেন্টেশনে আপনাদের স্বাগতম। উক্ত আয়োজনে হোস্ট হিসেবে আছি আমি মোহাম্মদ ইফতেখারুল আলম, অ্যাসিস্ট্যান্ট একাডেমিক কোঅর্ডিনেটর BIIHR। জ্ঞানের অগ্রগতি, উদ্ভাবন এবং জটিল সমস্যা সমাধানের জন্য গবেষণা অপরিহার্য। এটি তথ্য প্রমাণ ভিত্তিক সিদ্ধান্ত ও নীতি গঠন করে, যা প্রসঙ্গ ভিত্তিক ফলাফলগুলিকে উন্নত করে, প্রযুক্তিগত ও চিকিৎসার অগ্রগতি বৃদ্ধি করে। উপরন্তু এটি শিক্ষা, সমালোচনামূলক চিন্তাভাবনা এবং সংস্কৃতির প্রচার করে। সামগ্রিকভাবে সমস্ত ক্ষেত্রে অগ্রগতি এবং উন্নয়নের জন্য গবেষণা অপরিহার্য। মূলত বাংলাদেশের শিক্ষার্থীদের মাঝে, বিশেষ করে স্নাতক পড়ুয়া শিক্ষার্থীদের মাঝে গবেষণার প্রতি আগ্রহ বাড়াতে এবং তাদেরকে গবেষণামুখী করে তোলার জন্যই BIIHR এর পথ চলা। আমাদের আজকের প্রোগ্রামের প্রেজেন্টার হিসেবে আছে ইব্রাহিম বিন ইসলাম। তবে এ পর্যায়ে পার্টিসিপেন্টদের উদ্দেশ্যে কিছু গ্রাউন্ড রুলস বলে দিই। প্রেজেন্টার সময় নেবে 20 মিনিট তার প্রেজেন্টেশনের জন্য, তিনি যে পেপারটা প্রেজেন্ট করবে। স্পিকার কথা বলার সময় কাইন্ডলি পার্টিসিপেন্ট যারা আছেন তারা মাইক্রোফোনটি মিউট করে রাখবেন। তবে হ্যাঁ, স্পিকার যদি বা প্রেজেন্টার যদি কোনো কিছু জিজ্ঞেস করে তখন আপনারা কথা বলতে পারবেন। আর প্রেজেন্টেশন শেষে একটা প্রশ্নোত্তর পর্ব থাকবে। উক্ত পেপার নিয়ে যদি কোনো প্রশ্ন থাকে আপনারা করতে পারবেন, হ্যান্ড রেজ করবেন, আমি সবাইকে কথা বলার সুযোগ করে দেব। তবে এক্ষেত্রে আমি প্রেজেন্টারের কাছে চলে যাচ্ছি। ইব্রাহিম বিন ইসলাম, আপনি কি প্রস্তুত প্রেজেন্ট করার জন্য?
জি, আর 2 মিনিটের মধ্যে আমি স্ক্রিন শেয়ার দিচ্ছি।
জি, আমরা আপনার অপেক্ষায় আছি। Okay, you can start.
Assalamualaikum everyone. I'm Ibrahim Bin Islam. Currently, I'm doing masters at the Department of Disaster Management and Resilience, Bangladesh University of Professionals. Currently, I am doing internship at BIIHR. Today, I am going to present a paper. It's a research paper, and the title of this paper is Dengue Disease Risk Mental Models in the City of Dhaka, Bangladesh. And the author of this paper, Dhar Chowdhury, 𝐎𝐫𝐷𝐿 and 𝐻𝐚𝐬𝐿 Driedger. Next slide. Abstract. Worldwide, more than 50 million cases of dengue fever are reported every year in at least 124 countries, and it is estimated that approximately 2.5 billion people are at risk of dengue infection. In Bangladesh, the recurrence of dengue has become a growing public health threat. Notably, knowledge and perceptions of dengue disease risk, particularly among the public, are not well understood. Recognizing the importance of assessing risk perception, we adopted a comparative approach to examine a generic methodology to assess diverse sets of beliefs related to dengue disease risk. Our study mapped existing knowledge structures regarding the risk associated with dengue virus, its vector, water container use, and human activities in the city of Dhaka, Bangladesh. Public mental models were developed from interviews and focus group discussions with diverse community groups. Expert mental models were formulated based on open-ended discussions with experts in the pertinent fields. A comparative assessment of the public's and experts' knowledge and perception of dengue disease risk has revealed significant gaps in the perception of disease risk indicators and measurements, disease severity, control of disease spread, the institutions responsible for intervention. Next slide. This assessment further identifies misconceptions in public perception regarding causes of dengue disease symptoms, dengue disease severity, dengue vector ecology, dengue disease transmission. Based on these results, recommendations are put forward for improving communication of dengue risk and practicing local community engagement and knowledge enhancement in Bangladesh. Next slide. These are the keywords: Aedes mosquitoes, dengue, infectious disease, mental map, public health, and risk perception. Next slide. Introduction. Dengue disease as a global health concern emerged following World War II and rapidly spread across the tropics and subtropics in the wake of rapid population growth, urbanization, inadequate basic housing, climate change, increasing air travel, and expanding international trade. The disease is endemic in these regions via the main vector Aedes and mosquitoes which prefer to breed in water-filled containers and in domestic and peri-domestic environments, widespread to at least 124 countries worldwide. More than 50 million cases of dengue fever are reported every year. It is estimated that approximately 2.5 billion people are at risk to dengue infection. In Bangladesh, a tropical country in South Asia, periodic outbreaks of dengue have been recorded since 1964, with the first epidemic in dengue disease risk mental models resulting in 5,553 hospitalizations and 93 deaths. The risk of infection remains high among the urban population, and the potential for future outbreaks has become a subject of serious concern among members of the public health community. In the absence of a vaccine, the most feasible strategy for controlling dengue transmission is vector control. Applicable methods include eliminating larval habitats, reducing adult mosquito abundance and lifespan, and preventing mosquito human contact. During the 1980s, Aedes control programs shifted from large-scale aerial spraying to community-based programs, a change chiefly attributable to decentralization of health services, the breakdown of vertical control programs, and shortages of trained technical personnel. Next slide. In this context, finding sustainable solutions for dengue vector control requires addressing not only technical and financial challenges but also gaps in local knowledge with respect to risk identification and the cultural beliefs, attitudes, and practices that prevent public health initiatives from being successfully implemented. Understanding how people perceive the risk associated with dengue disease and its vector may help to at least partially solve this problem. Dengue disease burden represents a complex problem involving ecological, biological, and societal factors because it is viewed from many perspectives by different social actors in different parts of the world. In short, the definition and meaning of dengue is cognitively situated in people's specific circumstances and time in their life stories. Regardless of clinical conditions, the wide adaptations to new and modern contexts of dengue go beyond the domain of expert scientific knowledge that is as solely a clinical issue. A comprehensive assessment of dengue disease risk must therefore encompass local experimental knowledge, belief systems, norms, and customs in addition to modern medical knowledge. Following Slovak and Slovic and Weber's definition of the general term risk perception, we view the dengue disaster risk nexus in this article as an integrated cognitive frame of reference that humans apply to understand and deal with the dangers and uncertainties of life stemming from human exposure to dengue virus. It is critical to recognize that perceptions of dengue disease risk are inherently subjective, interrelated with culture and social context, and can vary when public and expert systems of knowledge and perceptions are compared. The ultimate purpose of mapping risk perception of dengue and other impairing infectious diseases is to develop better tools and programs for educating individuals and communities, allowing them to more effectively implement their own preventive measures and reduce the risk of dengue infection. Risk perception of dengue disease. Our research investigated a complex set of interrelated risk perceptions of dengue disease in urban communities, primarily at the collective or group level. In the city of Dhaka, Bangladesh, it is notable that although collective risk perception of diseases is not simply the sum of individual perception, this distinction has generally been absent in the literature. We begin with a critical review of the role and significance of research on risk perception of dengue disease, its associated vector and transmission process, and related to preventive behaviors. F. Fishoff et al. Succinctly argue both individual and collective decision making process are critical in explaining the role of risk perceptions in public health risks risks stem from deliberate decisions made by individuals as well as from exogenous environmental or institutional sources. To make decisions, individuals, groups, and regulatory organizations are required to comprehend the risks and benefits associated with alternative courses of action, although measuring and analyzing health and disease risk perception among various stakeholders could be mm, daunting due to differing definitions and perceived meanings. It is necessary to map these variations between mental models. By defining lay epistemologies as the defined ways in which people view, conceptualize, and engage with the world, Medin and Bank assert that these differences implicitly and explicitly affect knowledge construction and forms of engagement with the world, and that disease risk perception research must thus account for these epistemological aspects so that the underpinnings of variations in knowledge perception and decisions regarding disease management can be fully understood. Fishoff and 𝐬𝐴 further emphasize that for the purpose of effective scientific and medical communication, it is essential to learn what lay people do and do not know through empirical investigation. In recent years, to support collective decision making, an application of mental model elicitation techniques to construct a collective representation or shared mental model of a given system has been encouraged. Several authors have argued that it is fundamental to the successful take of health interventions that community members are engaged in mapping perception of disease risk exercises. Next slide.
আচ্ছা, আপনাকে বলে রাখি আপনার হাতে আর 10 মিনিট সময় আছে।
EP and Semenza assert that community knowledge, attitudes, and uh, practices, as well as participation with a sense of ownership, and are important to improving risk perception, risk reduction behavior, and disease control effectiveness. 𝐬𝐤𝐝 as and 𝐸𝐴 further underscored that local perceptions of dengue disease risk are a critical factor in the performance of intervening programs, as they significantly influence motivation toward participation in mosquito abatement. Several studies in Asia and Latin America have confirmed that while knowledge of dengue disease among community members has generally been high, perception of dengue disease risk was much lower than among experts and risk managers. Gaps were also recorded between perception and practice in local communities. Studying three districts in southern Taiwan concluded that although most respondents knew that mosquitoes transmit dengue and that removing unused water containers is an effective preventive measure against dengue exposure, the percentage of families that frequently cleaned water-filled containers and ditches around their residences was low. Similarly, in a study of three commonwealths in southern Vietnam, Tran et al. Recorded a clear understanding among most participants that DF was a water-related disease and that water storage containers were potential breeding grounds for mosquito larvae. They observed that although the community members were knowledgeable about dengue disease risk, they still stored water in locally available containers, particularly during the dry seasons. Next slide. Research approach and design. The process of formulating mental models that we pursued can be distinguished from traditional methodologies for mental models, which apply the expert influence diagram as a structural template to steer the community member content analysis in making comparative analysis. Based on the idea generating strategy of the Delphi process, we attempted to preserve a strong contextual element in which the public model was based primarily on community members' own and collective or shared understandings and concerns. Methodologically, mental models are captured through the drawing of influence diagrams, which are basically directed networks composed of arrows or influences connecting related nodes. These illustrate the relationship between complex variables with factors influencing each other in direct and indirect ways. This representation also provides a convergent validation for experimental results, although the influence lines embody both positive and inverse relationships between variables. Analyzing these directional aspects was beyond the scope of the present study. Next slide. Our study modified a generic methodology for understanding knowledge, beliefs, and practice about dengue disease risk in the city of Dhaka, Bangladesh. Conventionally, the mental model treats expert knowledge and perception as the benchmark for understanding the causal links between various relevant elements. The formulated expert mental models are then compared with general public mental models that capture the public's knowledge, perception, and beliefs. We have next slide results. Uh, The socio-demographic characteristics of the public and expert mental models of dengue disease risk participants are depicted in table among the 65 respondents to the survey and participants in focus group discussions. The majority were men between the ages of 25 and 44. More than 15% of the public mental model participants never attended school, and only one third had an educational background beyond grade 12. Occupationally, 82.8% of the women participants were unpaid laborers, and most men were involved in various wage earning activities related to health services, retailing, semi-skilled apprenticeship, day labor, and rickshaw peddling. Expert model participant characteristics were skewed toward higher educational attainment and occupational categories, reflecting the predominance of male educated high income earners among the professionals and knowledge stakeholders. Next slide.
আপনার আর 3 মিনিট বাকি আছে।
Public mental models. The influence diagram representing the public mental model of dengue disease risk as centered around environmental variables, land use changes, water poverty, and resultant poor health. It was observed that a causal link among uh, these factors was not systematically conceptualized in public cognitive process. Next slide. Knowledge and perception of dengue disease and its causes. The results of our study revealed that the overall level of awareness regarding dengue among local community members was low, while all the public participants who answered individual questions during the orally administered surveys have heard about dengue. Only 38.5% of the respondents believe that dengue poses a serious threat to public health. Out of 65, only two respondents remembered the first major outbreak of dengue in Dhaka 2000. All were also aware of the disease resurgence in subsequent years. A total of 72.3% public participants knew that mosquitoes are the primary vector of dengue. However, most local community members were unaware that Aedes aegypti mosquitoes prefer to lay their eggs in water containers. Responses of community members overall did not reveal a clear understanding of the dengue virus, Aedes mosquitoes, water containers, nexus, and misconceptions of regarding dengue disease transmission were registered in several areas. Next slide. Experience, knowledge, and perception dengue of disease symptoms. Dengue symptoms and signs include fever, uh, backache, arthralgia, headache, generalized pain, eye pain, lacrimation, scleral injection, anorexia, nausea, vomiting, pharyngitis, upper respiratory tract symptoms, relative bradycardia, prostration, depression, hyperesthesia, and rash. Since 2000, physicians in Bangladesh have clinically diagnosed dengue according to WHO protocols. The diagnosis can be confirmed by the presence and or seroconversion of dengue antibodies. Confirmation of dengue virus presence via RNA PCR is available in specialized laboratories. In recent years, commercial ELISA kits for detecting viral antigens have become more widely available. Early clinical diagnosis of DF is crucial to reducing morbidity and mortality, as the disease left untreated may progress into DHF or DSS. Although the pathogenesis of severe dengue is not understood yet, it has been found that the risk of severe disease is increased at least 15-fold during repeat relative to primary dengue infection. Suggested mechanisms include antibody dependent enhancement, complement activation by virus antibody complexes, T cell mediated immunopathology, and variations in viral genotype virulence. As no existing antivirus are effective against dengue, treatment is limited to supportive care, emphasizing fluid replacement and management of shock and organ dysfunction. Aspirin is avoided due to risk of hemorrhage. These treatments are effective if applied meticulously and in a timely manner. In Bangladesh, with intensive supportive care, mortality rates are 2% or less, irrespective of socioeconomic background. Any citizen can receive these treatments if she or he attends a tertiary level hospital. This research was made possible through funding from the International Development Research Center (IDRC), Ottawa, Canada. Uh, mm, Further financial assistance was received from the Manitoba Health Research Council through the Graduate Studentships Award, and from IDRC Ottawa through the IDRC Doctoral Research Awards. To the first author, the authors would like to acknowledge the extensive support provided by the Department of Public Health of North South University Population Services Training Center, Directorate General of Health Service, Dhaka, Bangladesh. They are thankful to the study participants in Dhaka communities for having confidence and trust in the interviewers and sharing sensitive information with the research team, and Senior Program Officer, International Development Research Center, Ottawa, Canada, for his assistance in designing the focus group discussions and the key informant interviews, and to Hassan Mahmoud, Natural Resources Institute, University of Manitoba, Canada, for his assistance in preparing the map. There are no funding or competing interests. Thank you.
ধন্যবাদ ইব্রাহিম বিন ইসলামকে।